BBC Sounds. Music, radio, podcasts.
Hello. Meningitis. Every parent's nightmare. It can strike anyone at any age, but around half of those with the most serious form, meningitis B, are toddlers and young children. And the effects can be devastating.
This is me, Ezra.
So this is Ezra. He's 3 years and 9 months. And he has lost his lower limbs below the knee. And he's missing 4 digits onto his right hand.
I visit a busy paediatric emergency department in Belfast to see a new bedside test for meningitis B that should help children get the right treatment and get it faster. And I meet the team behind new research into the benefits of do-it-yourself monitoring for one of the most common causes of blindness. But first, life-threatening allergy or anaphylaxis and a shortage of devices used to treat it. Inside Health listener Elizabeth has 2 children under 10, both with severe allergies. Her daughter is allergic to eggs, her son to sesame and eggs. They both have adrenaline autoinjectors, Epipens Juniors, to use in emergencies. But when they approached their expiry date and Elizabeth tried to get replacements, she was told week after week that none were available.
My anxiety levels are sky high because there are none in stock and no news about when they will be back. The lack of guidance is staggering. The pharmacy was unable to supply alternative brands, Jext and Emerade either, and to have nothing when you've had children at risk of anaphylaxis is terrible. And I have had conflicting advice about whether we could carry on using their Epipens even though they're out of date. All very worrying.
Since contacting Inside Health, Elizabeth has been told that because her children are almost 25 kilos in weight, she can give them an adult dose, and last week was given 2 adult Epipens. She needs more for school and home, but it's a start. Margaret McCartney is in our Glasgow studio. Margaret, what's the latest on supplies?
Well, we've been told in the last few days that in Scotland, and the similar picture, of course, extends across the rest of the UK, that supplies are a bit dodgy and are expected to remain erratic and difficult until the end of this year. Now,
in Elizabeth's case, she had problems getting hold of the junior pens. Is this a problem for adults as well?
Well, it was a problem for adults, but the adult supply now seems to be a bit more stable, but it remains the Epipens Junior one that seems to be much more difficult to get hold of.
Elizabeth alluded to Jext and Emerade, which of course are the 2 other brands. Have there been problems with them as well?
Not as far as I know, but these are much smaller suppliers, so there simply isn't as much of these type of devices in circulation, which means you're much less likely to get one of these. And as far as I know, their factory supply hasn't been up to at least at a level that has met the demand that the EpiPen fall-off could meet.
What about this question about guidance in terms of has anybody produced definitive guidance on whether it's okay, for instance, to use your EpiPen past its expiry date? And if so, by how far?
Yes, so there are specific batches that we have been advised can be used for a few months beyond their expiry date, and you can look at those batch numbers on the Medicines and Healthcare Regulatory Authority website. There's a long list of them, and you can look at the small print in your EpiPen and try and work out if it's one of the batch or not that belongs to that. And the general advice is that these batches are safe enough to use in this, and don't get rid of your old EpiPen until you've got a new one. And of course, if it says it expires, let's say in November 2018, that means the end of November 2018, not the beginning of it.
What about using an adult pen in a child?
The current advice is that a child over the 25 kilograms could use an adult one if a child one is not available, which seems fair enough. But apart from that, I'm not aware of any guidance that says what we should be using if we can't get hold of a junior one. But to be fair, I haven't come across a situation where we have not been able to find a junior one, maybe even just one to give to a parent or family.
Do we have any idea when normal supply is likely to resume?
Well, not really. I mean, we've been told to expect disruption until the end of this year. And I suppose it's important to point out that we do get supply disruptions across all manner of medicines. This is unfortunately pretty commonplace. Whenever I'm on call, I always feel as though I spend half my time trying to find medications that are not in stock at one pharmacy and trying to get hold of them at another. So we have this, I suppose, this supply problem really across the board. And there are many medicines, and I'm sure many doctors and patients will describe very similar problems, trying to get something that's a fairly commonplace, normal medication suddenly goes out of stock and we can't get hold of it anymore.
Do we know what's gone wrong? Was there a manufacturing issue? I mean, obviously the manufacturer have got a vested interest in selling as many of these EpiPens as they can.
Well, yes. Some of the problems seem to be that stock that's intended for the UK market doesn't always end up in the UK market. Some people think this is because of the weak pound against a stronger euro or dollar. Sometimes supply problems originate with different medicines when one factory, for example, stops producing as many. And there's also very complex kind of quota systems that are operated and organised as well. The problem is that EpiPen has such a dominant share of the market that if something goes wrong with its supply, it creates quite widespread disruption. There are not the same number of different companies making the product that can easily take over that gap in the market.
Thank you, Margaret. Well, the shortages come at a time of heightened anxiety around anaphylaxis following the death of 15-year-old Natasha Ednan-Laperouse. Natasha died following an allergic reaction to sesame seeds, despite being given 2 EpiPen injections. At the inquest into her death earlier this month, the coroner, Dr. Sean Cummings, concluded that EpiPens are not fit for purpose because they don't contain enough adrenaline or have a long enough needle to deliver it. He's written to the manufacturer, Pfizer, and the Medicine and Healthcare Products Regulatory Agency, calling for action. Dr. Robert Boyle is consultant paediatric allergist at St Mary's Hospital in London and a researcher in children's allergies at Imperial College. Robert, that's a damning conclusion from the coroner.
Well, I was quite pleased to see the coroner raise these issues.
I mean, a lot of your patients must depend on these products, or similar.
Yeah, they do. And, it's a very anxiety-inducing situation because food allergies can kill a young person within minutes. And when a reaction happens and how severe it is are unpredictable. So at some level, people with food allergy need to be prepared for a really catastrophic event at any moment in their lives. And that's obviously very difficult to balance with having a normal, healthy life, doing the sort of social and dietary activities that you'd want to do. So I was pleased to hear the coroner raise those issues.
Are they familiar issues to you? I mean, do you worry about the devices that people are using?
I think there's widespread concern amongst the allergy community that these devices are not as good as they could be. We're fairly sure that adrenaline is the right drug to treat an allergic reaction and that the dose that's being administered through these devices is a safe dose. But there are a number of issues with the devices, starting with those that the coroner raised. The length of needle. For a skinny person, they need a short needle. For an overweight person, they need a longer needle. And each device just produces one needle length for the dose. So there's an issue that the needle length is not always right for the right person.
I mean, it seems incredible to me. The EpiPen's hardly a new device. It's a market leader. It's been around for a long time. You would have thought that this is a big market, that they've got this device absolutely perfected by now. Would you not?
Well, it's remarkable when you look at the device and its history, how little innovation there's been with the adrenaline autoinjectors in general. EpiPen we've had since the 1970s, and for some time we've been aware that it's difficult to use in an emergency. It's not a sort of size and shape that every person wants to carry. The doses do not encompass the usual dose for treating anaphylaxis in a young adult or teenager. And then there's the issue around the needle length, which has been highlighted by the coroner and also by the MHRA, the regulatory agency in the UK.
But why hasn't there been much innovation in this area? I mean, I get the feeling that you and your colleagues would like to see more innovation in this area. Is that correct?
Of course, and I think the patients would too, and their parents. People want better devices that are fit for purpose. I think at one level, the industry may not need to innovate too fast because they are selling a lot of devices. This is the best we've got. It's almost certainly better than nothing. So we're sort of reliant on the supply of adrenaline autoinjectors without being able to create enough competitive pressure for the companies to innovate.
Talking of competition, there are 2 other brands which we've mentioned. Is there any evidence medically that they're better than EpiPen in any way? Have they addressed any of the issues of the shortcomings of the EpiPen?
Well, I think it's good to see some changes there. The Emerade device has the correct dose available for an adult or adolescent, and it has a slightly longer needle length. And those are 2 issues which have been brought up time and again around the EpiPen. So there are 3 devices available. They've all got their strengths and weaknesses. None of them are perfect, but I think it's a positive thing that there's some degree of competition there.
Familiarity must be very important here. I mean, I'm thinking of the supply issues. If people were to switch to one of the others, you need to know how to use it, don't you? You don't want to get it out for the first time to use it in anger.
Yeah, and that's the disadvantage of having some competitive activity there. switching from one device to another, and I think an important message for patients in the current situation where you may be switched from one device to another because of the supply shortages, is that if you're switched to a new device, you need to make sure that someone shows you how to use that new device.
What about this thing about using adult pens in children? What's your position on that? Can you give someone too much adrenaline?
You can give someone too much adrenaline. In general, the doses that are used in the adrenaline autoinjectors have a good safety window. In some countries, they will use an adult pen for a 20-kilogram child and above. Our policy in this country is to use a 300 microgram, an adult dose of an adrenaline autoinjector for a 25-kilogram person or heavier. So there's probably some flexibility there around the 20 to 25-kilogram mark, but I don't think you'd want to give the adult EpiPen to very young children because there's a real possibility of causing some harm in a young infant, for example.
What about the impact of these devices over the years since they've been introduced? Are we seeing fewer people die from anaphylaxis?
Well, there's certainly been a huge increase in the number of these devices prescribed and sold, both in the UK and overseas, in the last 20-25 years. Disappointingly, we haven't seen a big inroad into the number of fatalities. So there is a question there of how effective the devices are overall. But they're the best we can get. They're the right drug for treating anaphylaxis. We know it works. We see it works under our eyes in hospital and in clinical studies. There's the right drug, and it's a safe dose. It may not always prevent the tragic outcomes, such as the one you described earlier, but I think it's the best we can get. So we do need a safe supply and a reliable supply of adrenaline autoinjectors, and all the charities, professional groups and regulatory agencies in the UK are working hard to try and ensure we've got a supply in this country which people can rely on.
Dr. Robert Boyle, thank you very much. More details, as ever, on the Inside Health page of the Radio 4 website. There are lots of different types of meningitis, but it's the bacterial form that tends to be the most serious, in particular infections caused by the Meningococcus family. The most common strain in the UK and the most feared is Group B meningococcus. It's a rare infection, not least because of the recent introduction of the new meningitis B vaccine. But last year there were still 400 cases in England alone, just under half of which were toddlers or babies.
My name is Ezra, and I am 3.5. 1, 2, 3, 4, 5. Once I caught a fish alive.
So this is Ezra. He's 3 years and 9 months. And he has lost his lower limbs below the knee. And he's missing 4 digits onto his right hand. Ezra, do you want some cake?
Nope. This is me, Ezra, the baby. And I want to hear Superman.
My name is Serena. Ezra's mama. He wasn't well the days before, and I said, this is not right, we need to go and check with the doctor. Just looked at him and gave him steroids. They thought it's croup.
I realized he wasn't himself, so just decided the best way to do is just to go to emergency, to A&E. So we went to Belfast. So it was 2 hours by the time we got there, and we went to triage, and then we saw a doctor. It was just me and Ezra. He was very quiet. He was just sitting in my lap.
I was starting to get concerned at work, and I kept texting him and what's going on, and he couldn't get on the phone.
We saw the doctor in charge, and he asked me to strip him down to his nappy. That's when a few spots appeared on his body. He asked me about them, but then I realized that half an hour earlier I have changed his nappy and there was nothing on his body. And then by the time the doctor went away and came back, there was more spots appeared. Also in the meantime, my wife came from work, because I got in contact with her and I said, look, you might have to come here and stay with Ezra in the hospital for a few days.
I got there and...
You had a bag full of clothes for yourself and for him. The doctor in charge, she asked me at one stage, do I know what meningitis is? Because she believes that Ezra has meningitis. And then later on, it was actually meningococcal B, and which transformed in septicemia as well.
When she mentioned septicemia, I kind of clicked because I knew septicemia is quite critical. And then we got to ICU. And
the nurse came to explain to us, and she did mention that he is in a very critical condition. We don't know what's going to happen. The next 24, 48 hours are very, very critical. We can't say anything at this stage, but your son is very, very sick.
We asked, do you mean he's going to die? And she didn't say that, but she kept saying to us, he's really sick. The chances were quite low.
By 8 o'clock, he was in an induced coma, full of spots by that time. The way the disease progressed was shockingly quick. And nothing can prepare you for that. The trauma was so big that I could not accept the fact that, Ezra is gonna die.
Doctors tried different procedures to try to save the limbs, but they couldn't. I think it was 2 weeks after he got sick, we kind of lost our hope.
I mean, the miracle is the fact that he is with us.
Yeah.
But would have been like a top up to the miracle, the fact that he would have kept the legs at that stage.
Doctors said, look, you want to save his life, we need to do this. So his life was first. He's such a good boy. He is brilliant. He's a miracle from the beginning. He goes to nursery, he goes to different classes, dance, he likes books, and
he likes dancing.
He likes dancing, yeah. I think he's a bit of an artist.
It's amazing to see how much they can actually run on the prosthetics and how far he got. The way he was in the first few weeks with them, and now seeing him running, it's unbelievable.
Okay.
A lively Ezra with his dad Cosmin and mum Serena. Ezra was treated for meningitis B at the Royal Belfast Hospital for Sick Children in Northern Ireland. One of those looking after him was paediatrician Tom Waterfield, who, inspired by Ezra, is working with a team from Queen's University to develop a rapid bedside test for Group B infection, something that's all too easy to miss in its early stages. I've come to the busy Children's Emergency Department here at the hospital to meet Tom and see the result, the Loop-Mediated Isothermal Amplification Test, or LAMP for short.
Okay, so come on through. This is our room with all our point of care testing. Thankfully the kit's nice and small so we can squeeze in. So this here is the device. It's as you can see, it's really quite small, about the same size as maybe a landline phone or something you'd have at home.
Yeah.
Which means we can take it out of the lab and bring it into this little room to do our testing. So
proper desktop test.
The main aim here is all about trying to get results fast.
How do you actually use it?
We'll just take a throat swab. You can also use blood and you can use spinal fluid, but we prefer to use a throat swab in children. The particular bacteria we're looking at, the meningococcal bacteria, it releases large amounts of DNA, which we can detect. So you can either get live bacteria and grow them, and you have to wait for the bacteria to multiply. We can't really speed that up. Or what we can do is we can say, well, we'll break open the cells, release their DNA. We're looking for the DNA, not in everyone, but in children who have got some signs and symptoms which could be suggestive that they've got this early signs of this serious infection.
And that will give you a result how quickly?
We get a positive result typically in under 20 minutes. We like to run it for 40 minutes before we'll say it's negative, just because if there's really small amounts of DNA, we want to give a chance for the test to amplify them and to detect them, if that makes sense.
And it's detecting tiny traces of the DNA of the bacteria that's causing the infection.
So we can detect down to less than 10 copies of DNA. Typically, if we would have swabbed a child with an infection, they would have millions of copies of DNA present at that time.
And to put that 20-minute wait in context, what's the quickest test that you have to confirm that someone's got meningitis infection at the moment?
When we're looking for the meningococcal bacteria, The tests we can have blood cultures which take 48 hours because we have to wait for the bacteria to grow, or we can use the PCR in the laboratory. Some of the hospitals we're working with in this study, it can take them a couple of weeks to get results. For us here, we're quite lucky, we'll get them back in 2 to 3 days.
So this sort of technology is already available. What's different here is its desktop application. It's right next to the patient.
So it's the difference is that it's right next to the patient, and it also doesn't need a specialist to perform it.
Dr. Tom Waterfield with the new bedside lamp test for meningitis B that could mean children like Ezra are diagnosed more quickly, but which also could be used to rule out infection in others who might otherwise be given high doses of antibiotics they don't need, increasing resistance. AMD, age-related macular degeneration, is a leading cause of blindness across the world, with at least 500,000 people living with the condition in the UK alone. There are two types, the more common, dry AMD, and the less common but more damaging wet form, which requires early treatment to prevent progressive loss of vision. Dr. Ruth Hogg is from the Centre for Public Health at Queen's University, Belfast.
The macula is the part of the sort of film at the back of the eye, the retina, that we used for our detailed visions, for reading, for recognising faces, for appreciating colours. So there's a lot of our day-to-day tasks that require that part of the eye to be healthy and working properly. The early stages of the condition, a patient may notice problems adjusting from dark to bright lights or when they're getting up in the middle of the night. But then as it moves on to the more severe forms, the geographic atrophy or the neovascularization, so then it's actual problems with reading and with recognising faces. Lines of text may look jumbly, or the edge of a door they may see it's no longer straight. Those are some of the symptoms that a patient may notice.
And it's a tricky condition because it affects the macula. It's basically what you're looking at. So you might get some preservation of your vision on the periphery, but the bit you really want to see, the bit you're looking at is difficult to see.
So it is. What's affected in AMD is a straight ahead vision, and the periphery may be preserved. So it means that a patient may actually be okay at moving around. Mobility may not be affected to the same degree, but they have really profound difficulties in reading and recognising people, looking at photographs, TV, embroidery, crosswords, the kinds of things that lots of older people enjoy to do.
My name is Patricia Strong. There's a history of macular within the family. My mother had it.
Was your mother badly affected?
She was. She was blind. She had to wear dark glasses and things. So all the family were tested, my brothers and my sister. Then about 2 years ago, I was just getting a routine eye test, and the lady there, she didn't exactly say I had it, but I knew what she meant.
Had you been experiencing any symptoms from your vision?
Not really, no. But when I did come to the hospital, things started to get a wee bit deteriorated.
In what way?
I couldn't see the TV properly. And then I woke up one day and it was or one evening I was sitting watching the TV, and all of a sudden the newsreader or whoever was on, the face became very distorted, like wavy lines. And I knew then there was something quite serious. So I phoned up and they brought me in right away.
And the diagnosis was?
Macular wet in one eye and macular dry in the other eye.
Patricia had a course of injections followed by regular checks to make sure the characteristic changes of wet AMD at the back of her eye, leakage and new blood vessel growth didn't start again. Monitoring is essential. Dr. Ruth Hogg.
In about 30% of people, the leakage will reactivate again. So then they go into sort of a monitoring phase of treatment where they still have to come in regularly to get their vision checked and the images taken off the back of the eye. So because there's so many people affected by the condition and the treatment schedule is quite intense, that then it's a huge problem for the NHS to be able to allocate the time and the resources to this, and then it's also incredibly inconvenient for patients and their family members who are having to come for the appointments.
So I'm just going to go into the test here, show you how to set it up, and you'll hear some instructions as to how to carry it out.
Please patch your left eye now. Then press the start button to begin the eye test.
Okay, so as you can hear, the test is telling you exactly how you would carry it out. If you want to put your eye patch on, and then we'll continue. Perfect. And then a little bit harder.
Patricia has volunteered to take part in a trial, the Monarch study, where patients can avoid the monthly journey to hospital by taking vision tests every week in the comfort of their own home. Research optometrist Leslie Doyle shows me the 3 methods being tested.
One's a paper-based test, and then there's 2 electronic tests, which are done using an iPod device.
And this paper-based one is the booklet. I mean, it looks like a puzzle book, effectively.
Yeah, and that's essentially really what it is. It's using puzzle-like vision tests, and they kind of take the form of puzzles that patients might be used to completing, such as word searches, crosswords, and that type of thing.
A bit like the eye chart here, is the standard eye chart, and they have to tick which line that they can read. But
kind
next to it is what looks like an iPhone, or similar.
Yes.
And that, I suspect, might be a bit more scary for some of the patients that you're dealing with.
Certainly some patients are a little bit apprehensive about using the iPod device, which is why we bring them in and let them have a look and a trial with it before deciding whether to take part or not.
Start.
The aim of the test here is to try and locate the odd one out.
Please touch a circle. It's okay to guess.
So if you want to have a look at the circles, and just place your finger on top of the circle which you think is the odd one out. Perfect. So as you can see, every time you get the answer correct, it becomes a little bit harder.
But this is a group who've got difficult central vision. When they're looking at things like iPads and iPhones and pieces of paper, they struggle already. Can they do this sort of test?
The good thing about the treatments that are being used now is that if people are detected early and treated early, they actually are retaining quite good vision, and there is a lot of people with wet macular degeneration are still within the driving standards, so those are the people that we will be targeting for the study.
But the hope would be that the home testing gives you as good a follow-up or similar follow-up to being seen in the hospital.
That would be the hope, that some of those appointments, they wouldn't have to happen anymore, and then that would free up the resource to concentrate on those that need treatment or those that are needing diagnosis.
Let's just say the numbers out loud that you see flashing up on the screen.
Okay. 29 60 63.
How do you feel about the idea of being able to some extent, monitor yourself at home?
I'm happy enough with it. I really am.
It's got to be less time than coming into the hospital and trying to find a car parking space.
Yeah, that's very true, yeah.
Patricia Strong talking to me in Belfast. More details on AMD and Ruth Hogg's Monarch study on our website. Next week, surgery for aortic aneurysms and the latest on pregnancy and preeclampsia.